Hi, I'm Joe Graydon.
I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy, where we bring you the stories behind the health headlines.
This podcast is brought to you by Redix Industries, makers of Utterly Smooth Body Cream. 800-345-7339, on the web at uttercream.com. Millions suffer from either too little or too much thyroid hormone. What are the latest developments for treating thyroid problems? This is the People's Pharmacy with Terry and Joe Graydon.
For decades, doctors thought that diagnosing thyroid disease was relatively simple. Just look for one blood test, thyroid stimulating hormone, or TSH. But in the last several years, it's become clear that there are subtleties that need to be taken into account when interpreting such tests.
Dr. Antonio Bianco is a leading thyroid researcher. He'll explain why some people don't feel good on standard treatment. Mary Showman offers a patient's perspective.
Coming up on the People's Pharmacy, we get up to date on treating thyroid disorders.
First, this news.
In the People's Pharmacy health headlines, are you getting enough shut-eye? Sleep scientist Matthew Walker says that skimping on sleep can shorten your life. That conclusion is based on an analysis of 20 different studies. One study showed that people over 45 were twice as likely to have a heart attack or stroke at some point if they slept fewer than 6 hours most nights instead of 7 to 8 hours. Sleep deprivation also hampers immune system activity. Those who strive for few hours of sleep a night may be setting themselves up for dementia or obesity, or at least an increased risk of those disorders. Concentrating on getting a good night's sleep may be as important as adequate exercise and a healthy diet in boosting well-being and longevity.
Although chronic sleep loss is a problem, short-term sleep deprivation may be an effective antidepressant for some people. A meta-analysis conducted by researchers at the University of Pennsylvania showed that both partial and total sleep deprivation could reverse depressive symptoms quickly for up to half the patients studied. Partial sleep deprivation is affected by keeping people awake for 20 or 21 hours after just 3 or 4 hours of sleep. Total sleep deprivation requires people to stay awake for 36 hours straight. Both tactics appear to be equally effective.
Given that sleep problems are common and troublesome, it's not surprising that many older people take over-the-counter or prescription sleep medicine on a regular basis. Almost 1/7 of those who report difficulty sleeping at least 3 nights a week take prescription sleeping pills. Often, people rely on such drugs for many years, although the medications are labeled for short-term use only. Many older people who don't sleep well don't talk with their doctors about this problem, even though some of them report that pain is a factor keeping them awake. These results are based on a poll of more than 1,000 people by researchers at the University of Michigan.
The FDA joined an international crackdown on illegal drug sales over the Internet. As part of the international effort, customs officials, regulatory professionals, and police seized millions of doses of pain pills, dietary supplements, epilepsy drugs, and medicines for erectile dysfunction. The FDA concentrated primarily on websites that sell opioids and ship them to U.S. customers through the mail. FDA Commissioner Scott Gottlieb noted these rogue online pharmacies are often run by sophisticated criminal networks that knowingly and unlawfully distribute illicit drugs, including counterfeit medicines and controlled substances.
When the FDA approves new medications, it frequently asks the manufacturer to conduct further studies. This would allow the agency to collect more information on side effects and dosing while still allowing the drug on the market. In most cases, the drug maker agrees to carry out such post-marketing studies, but too often they fail to complete them. An analysis published in the New England Journal of Medicine found that 20% of approximately 600 trials required in 2009 and 2010 had never been started. Another 9% were delayed. The FDA asked the maker of Suboxone if the drug causes a particular heart problem. The trial was to have been completed in 6 years, but as of July 2017, it was not clear that a final protocol had been submitted and approved. Another study was to have been done on a lower dose of the multiple sclerosis drug, fingolimod. The manufacturer says it has had trouble recruiting study subjects. Despite that, it has managed to sell almost $3 billion of the drug. The researchers call for greater transparency in the FDA's post-approval database.
Lifting weights makes your muscles stronger. It may also make you feel less anxious. An analysis of 16 previous studies found that people randomly assigned to do resistance training had less anxiety than those assigned to do nothing. Most studies on the mental health benefits of exercise have focused on aerobic activity. This study shows that resistance exercise also can improve mental health. In the studies, the subjects lifted weights 2 to 5 times a week for approximately 3 months. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Millions of people suffer from thyroid problems. They may make too little or too much thyroid hormone. Because the thyroid gland is critical to virtually every cell in your body, this has profound implications for people's health.
To help us better understand the function of the thyroid gland, we turn to endocrinologist Antonio Bianco. He's the Charles Arthur Weaver Professor of Cancer Research in the Department of Internal Medicine at Rush University. He's president of Rush University Medical Group and vice dean for clinical affairs in Rush Medical College.
Welcome back to the People's Pharmacy, Dr. Antonio Bianco.
Thank you very much. It's a pleasure to be here.
Dr. Bianco, levothyroxine is the most prescribed drug in the United States. At last count, 123 million prescriptions were dispensed. And that doesn't count prescriptions for brand name drugs like Levoxyl or Synthroid or Unithroid. Why is thyroid dysfunction so common in the U.S.?
Well, actually, thyroid dysfunction is common worldwide. And it is because it's a very common disease. Most of the time, it's the result of an autoimmune process. There's a disease that's called Hashimoto's thyroiditis that causes slow and progressive destruction of the thyroid gland. And the older you get, the more likely you're going to develop that.
Well, Dr. Bianco, I think there's a lot of confusion about Hashimoto's thyroiditis. Do we have any idea how it gets started and what's the progression?
We don't know much about it. What we know is that at some point in life, the immune system, our immune system, no longer recognizes certain molecules, certain components of the thyroid gland as being belonging to our body. So the immune system starts to produce antibodies against those specific molecules present in the thyroid gland. And therefore, they want to destroy the thyroid gland. I mean, some cells of the immune system also infiltrate the thyroid gland and sit there and start to destroy the thyroid cells. Therefore, it starts with the presence of antibodies in the blood. Patients might not have symptoms from hypothyroidism because the thyroid gland is relatively large, so it contains many cells producing thyroid hormone, so that at the beginning the destruction is not perceived as a hypothyroidism just because you still have a lot of normal cells that keep producing thyroid hormone.
What are the symptoms of hypothyroidism?
Well, the symptoms vary patient by patient. The symptoms include having a foggy mind, being tired, being sleepy, not able to focus on specific things, not willing to move, to walk around, or the patients will say, well, I sit in my chair and I want to stay there the whole day, or I don't want to come out of my bed in the morning. There are also some objective symptoms like constipation, dry skin, hair that's falling more frequently. But unfortunately, all of these symptoms are non-specific. So a number of conditions can manifest themselves with these symptoms as well. That we don't have one specific symptom that the physicians can use and say, well, because you have this, then your diagnosis is most likely hypothyroidism. No, we don't have that.
So most of the time, the diagnosis is made by looking at TSH levels.
That's correct.
And yet you and your co-authors in a recent article that was published in May of 2017 in The Lancet acknowledged that the diagnosis is becoming somewhat controversial. Can you let us in a little bit on what doctors are debating?
Well, what happens, so first it depends on the range of the TSH. What is a normal TSH? So there's a debate around that. The range is somewhat wide, so it's not a narrow range, it's wide range. And the higher the TSH, the more likely you have hypothyroidism. So there's a gray area in the upper limit of normal. So, normal individuals will have a TSH that fluctuates between 1 and 2 or 3. And then if you have a TSH that's 5, do you have hypothyroidism or not? How about 7 or 8? So there's an agreement somehow that patients are diagnosed with hypothyroidism for sure when their TSH is greater than 10. Between the upper limit of normal, which is around 4 or 3.5 and 10, it's a gray zone. That's the first controversy that we have for the diagnosis of hypothyroidism. Now, the second thing is when you're treating someone with hypothyroidism, you need to adjust the dose of the thyroid hormone replacement therapy. No matter how you're doing this, what are the medicines that you're using, you need to adjust the dose. And we use the TSH to adjust the dose. The rationale is, okay, TSH was high. We are going to start patient with the thyroid hormone replacement therapy, and we're going to bring the TSH back to normal again. Now, when we do this, and this is the standard of care, this is what every physician should do, we realize that even though you bring the TSH back to normal, you do not eliminate all symptoms of hypothyroidism in all patients. In many patients, in fact, the majority of the patients, you do. However, a small fraction of the patients, about 15, 20%, depending on the survey you look at, will have a normal TSH and yet will have residual symptoms of hypothyroidism. And we're starting to focus on this and try to understand why that is.
Do we have any idea why?
Well, the TSH reflects the thyroid level or the thyroid status inside the pituitary gland. That's where the TSH is produced. So when we adjust the TSH, we're making the pituitary gland happy. Now, with that dose, is that sufficient to make the liver happy? Is that sufficient to make the brain happy? And it turns out that it's not. Different tissues might need different amounts of thyroid hormone. And we are adjusting everything for the TSH. The TSH is an awesome indicator of thyroid function. However, does not reflect euthyroidism in all the other tissues. And we know for a fact that many tissues remain hypothyroid even though the TSH is normal.
We're told we're supposed to take this medication on an empty stomach, and that means in the morning, if you're taking it in the morning,
right,
you have to take it for at least an hour before you have any coffee. Some people find that pretty hard.
Yes.
Why is that important?
It is important because if you have food in your stomach, you're going to decrease the absorption. Now, you can say, I'm perfectly consistent. I always take the same amount of milk, coffee, or bread, and you can actually work with your physician and come up with a schedule in which you recognize that you're not being 1 hour fasting, but you understand that the absorption of the dose is not going to be complete. But if you're absolutely perfectly consistent, then you don't have to do that. However, the odds that you can do that successfully over time, over and over, every day, every year for many years are very, very small. So to avoid that problem, we tell patients you have to be taking this fasting because you eliminate those multiple variables that might exist. Now, I do have several patients that take levothyroxine at night before they go to sleep. Those individuals say, I have dinner very early, around 6 p.m., 6:30. I don't eat anything else, and I go to sleep between 11 and midnight. Can I take this at night? Yes, they can take at night. There's no problem. Actually, in fact, there are studies showing that if you are consistent and you take a dinner early and then you take your tablets just before you go to sleep, it's as good as replacement as early in the morning. But again, you have to be consistent because if you start eating close to the time you go to bed, then you're going to impair the absorption of levothyroxine.
Are there side effects from these hormones?
Levothyroxine, if taken to the right dose, has no side effects. I have some rare patients that will develop allergy to levothyroxine. In fact, it's not to the levothyroxine, but it's to the pill. Some pills have dyes, they have different colors, and some patients have allergy to those colors, to the fillers in the pills. So when that happens, we just change brand or go to different generic. We have to try different pills until you find something that the patient can tolerate. There are different formulations also that can be used. Now, there are side effects to liothyronine. Again, T3, liothyronine, is the active thyroid hormone. So the minute you take that, you put that in your body, it starts to act. So it's very potent, it's very active. Patients frequently refer that they feel tightness in their chest, they feel palpitations, they feel sweating. That means that we are giving too much T3 if that happens. Those symptoms should not be there. We should not be giving liothyronine to the point that we cause these types of symptoms. We don't want to do that. We want to decrease the dose of liothyronine, always adjusting based on the peak of T3 that patients will show 2 or 3 hours after they took the liothyronine. So I tell my patients, take the combination therapy in the morning and go to the lab. Make sure you go to the lab between 3 and 4 hours later. And that's the time you're going to get your blood sample because I will know how high the T3 is. And if the T3 is very high, that tells me I need to reduce the dose of liothyronine.
You're listening to Dr. Antonio Bianco. He's the Charles Arthur Weaver Professor of Cancer Research in the Department of Internal Medicine at Rush University. Dr. Bianco is also president of Rush University Medical Group and vice dean for clinical affairs in Rush Medical College. His research is focused on the enzymes that alter thyroid hormones.
We need to take a short break, but when we come back, we'll find out why so many people feel bad, even though their blood tests look perfectly fine.
Does it make sense to use combination therapy?
Yeah, and what is combination therapy? This notion of T3 and T4 together, it's starting to catch on. We'll also talk with thyroid patient advocate Mary Showman.
You're listening to The People's Pharmacy with Joe and Terry.
If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com. Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. 800-345-7339. The website is uttercream.com.
If you would like to purchase a CD of the show, you can call 800 800-732-2334. Today's show is 1096. That number again, 800-732-2334, or you can find it online at peoplespharmacy.com. You can also download the podcast from iTunes.
We're talking today about treating thyroid disease. Our guest is one of the world's leading experts on this condition. Dr. Antonio Bianco is the Charles Arthur Weaver Professor of Cancer Research in the Department of Internal Medicine at Rush University. Dr. Bianco is president of Rush University Medical Group and vice dean for clinical affairs in Rush Medical College. His research is focused on the deiodinase enzymes that alter thyroid hormones.
Dr. Bianco, why do so many people feel bad, even when their lab tests say, you're okay, you're fine? And what's the role for combination therapy, T4 plus T3, for people with hypothyroidism?
Yeah, well, that's the question I've been asked over and over again in the recent years. So first, we need to understand, are we sure we are giving levothyroxine to patients that have been diagnosed with hypothyroidism? That's the first question we need to ask. For example, if you're a patient that has symptoms suggestive of hypothyroidism, you don't have any other conditions. You're tired, your skin is dry, you have constipation, your motivation for physical exercise is down. So you go to a physician, you tell all this, and he or she will measure your TSH. Let's say your TSH is 4, which is in the upper limit of normal. Well, you have the symptoms, you have an upper limit of normal TSH. Many physicians will give you levothyroxine, okay? And you're going to start taking levothyroxine. Now, you would expect that those symptoms will go away. However, the symptoms don't go away. You go back to the physician and you tell, even though my TSH now is 1 because I'm taking levothyroxine, my symptoms are still there. So if you're a woman, and that happens frequently with me in the office, we find out that the woman, in fact, is in the perimenopausal period. So it's getting to that age where the menopause is going to happen. And the symptoms of the menopausal syndrome are very similar to the symptoms of hypothyroidism. Therefore, we actually treated someone thinking that that person had a hypothyroidism with levothyroxine. We didn't fix those symptoms. And yet later we discovered that the symptoms came from the menopausal syndrome. So we believe there are a lot of individuals taking levothyroxine today that might not have hypothyroidism. And they were started on levothyroxine, they were given diagnosis of hypothyroidism, and yet the symptoms don't go away just because of that. So that's one category. How large is that category? I don't know. We don't have an estimate of how many people. We think 15 million Americans have hypothyroidism. How many were misdiagnosed with hypothyroidism to start with? I don't think we know that number. It's probably not a large number. It's a small number, but it's a number that we need to consider. Now, the second part of your question is, I have someone that was diagnosed with hypothyroidism. The TSH was 20, was 30, and then we started that person on levothyroxine, and we normalized the TSH, and yet that person that did not have any symptoms before, let's say someone that had a thyroid nodule, underwent a thyroidectomy, a surgical removal of the thyroid gland, so that person does not have a thyroid gland anymore. Therefore, it starts with hypothyroidism on a date that we know exactly when that date occurred. And we start treating levothyroxine. So before the surgery, the patient didn't have any symptoms. And we start treating that patient with levothyroxine. The TSH is normal. However, that patient now has symptoms of hypothyroidism. It's not overt hypothyroidism, but, they start saying, well, I can't focus anymore. My mind is so foggy. I can't just focus enough. I have patients that lost their job just going through this story that I just told you. Patients that have a job that requires some focus, some attention, usually teacher, they can't just do this job anymore because starting from the day they had surgery, they can't go back to normal. So that story in the absence of any other justification, tells you that, are we normalizing the TSH? Are we doing enough for this patient? Is levothyroxine enough for this patient? So a lot of physicians think that levothyroxine for that patient is not enough. We would need to add some T3 to the treatment. It's called liothyronine. We would need to give levothyroxine plus liothyronine. There's an idea that those individuals will improve by giving liothyronine in combination with levothyroxine. And in fact, many do. I can tell you that based on my personal experience, many patients do improve significantly when you start combination therapy. But unfortunately, many patients don't improve at all. Many patients will just tell you, you started this, I have to take 2 pills, I don't feel any better. So we go back to monotherapy with levothyroxine. Therefore, I think we do recognize that a small fraction of patients, we're talking about 10, 15, 20%, do feel better with combination therapy. However, we don't know exactly who they are and when do we start combination therapy. As a rule of thumb for me, if I have a patient that I can attribute those symptoms to having hypothyroidism, for example, a thyroid surgery, they were fine before and they started with the symptoms after the thyroid surgery, and I cannot explain any different way why those symptoms are there, those are good candidates for combination therapy. But again, it's a trial. It's some patients will respond, some patients will not respond. If they respond, they're fine. They should be on combination therapy for the rest of their lives. If they don't respond, then they will have to work with the physicians and try to find out other ways of improving their quality of life.
Dr. Bianco, we're nearly out of time. I'm wondering if you would be willing to tell us about the research in this field that has you most excited.
What most excites me is I do believe we need to normalize serum T3 levels in patients with hypothyroidism. I do believe that when we treat patients with levothyroxine, we are not normalizing serum T3, the T3 in the blood. And therefore, we are not fully restoring the amount of active hormone in every tissue just because the T3 concentration in the blood is not normalized. So how do we do this? We try to do this by giving pills of T3. And in fact, those pills of T3, they produce a peak of T3 in the blood that's short-lived. It lasts for a few hours and then it goes away. So I think there's a lot of research. People are looking for ways of delivering T3 to patients in a way that maintains an increased level of T3 in the blood throughout the day and not only for a few hours. So that's one component of the research that I think we should be doing more than what we're doing today, but it's very exciting. The other component is to find out what are the clues that we could get from our patients that could tell the physicians, this patient will do well with levothyroxine alone, or this patient will benefit from having combination therapy. There are a lot of folks that believe there are genetic markers. So if we look into the DNA of the patients, maybe we'll find clues that will tell us which patients will benefit from what type of therapy. So those are the two major focus of research that excite me the most.
Do you anticipate a combination product in the near future that will do what you have suggested would be desirable, and that is to maintain a more constant level of T3 along with T4?
I hope so. I mean, I really believe that if people are paying attention to these fields, this is exactly what we need. I'm not aware of any products right now, but I believe that if people are reading the papers and looking at the research available, that's where pharmaceutical companies should be going.
Dr. Antonio Bianco, thank you so much for talking with us on the People's Pharmacy today.
It was my pleasure.
You've been listening to Dr. Antonio Bianco. He's the Charles Arthur Weaver Professor of Cancer Research in the Department of Internal Medicine at Rush University. Dr. Bianco is also president of Rush University Medical Group and vice dean for clinical affairs in Rush Medical College. You'll find a link to his paper in The Lancet from our website. If you'd like to hear more from Dr. Bianco, you'll find an extended interview on our website as well.
We turn now to Mary Showman. She's a patient advocate on a mission to educate and empower others struggling with thyroid conditions. Her website is thyroid-info.com, and she also has written a number of informative books. The most recent is Your Healthy Pregnancy with Thyroid Disease. She's a favorite guest on the People's Pharmacy and a force in social media. You can find her on Twitter at Thyroid Mary and on Facebook. We talked to her via Skype.
Welcome to the People's Pharmacy, Mary Showman. It's always great to talk with you.
Thank you, Terry. I really appreciate it being on with you guys.
Mary, we just had an opportunity to talk with Dr. Antonio Bianco about thyroid disease. He is certainly one of the world's authorities in this area. And he mentioned that about 15% of people have a hard time converting T4 to T3 because of genetic vulnerabilities. We won't get into the weeds on the details. And he kept saying this is a really tiny number. This is small. This is, not that big a problem. But I'm thinking, whoa, wait 1 minute, 15% of millions of people? I mean, that's a lot of folks who may not be doing so well on standard T4 treatment, levothyroxine. What's your perspective?
Well, my perspective is that Dr. Bianco is giving us the scientific verified component of the story, because patients have known for decades that a subset of thyroid patients didn't respond to just levothyroxine, to just a T4 drug like a Synthroid or a Levoxyl. Now we have evidence of one of the pathways that explains what is going on, this genetic difference in this 15% of the population that makes them unable to convert their T4 effectively to as much T3 as their body needs. But I think it's just one piece of a much bigger puzzle, because we know that a lot of patients simply do not have resolution of their symptoms on a T4 only drug. Some of the studies that have been done have shown that up to half of the patients studied, in some cases even more, prefer a T4 T3 combination therapy because it resolves their symptoms better. So I believe that we're just really at the tip of the iceberg, and that there probably are a number of other explanations that have yet to be researched and documented and put out as published findings that would explain why I believe a larger number than 15% of patients actually don't do well just on a T4 levothyroxine only therapy.
Well, Mary, I wonder if you'd explain that a little bit more.
Well, I think that the issue is that we've got two hormones that are the primary products of our thyroid gland, the T4 hormone, the T3 hormone. T4 is a storage hormone, or a hormone that gets converted into T3. T3 is the active hormone. It's what goes to our cells, tissues, organs, glands, and facilitates that delivery of oxygen and energy. So T3 is the active player in our bodies. And so we need that hormone for every physiologic function going on in our body, from growing hair to thinking to the heartbeat to digestion. Everything is dependent on having enough thyroid hormone. So if we are taking an exogenous thyroid hormone, we're taking a thyroid medication by prescription because we're hypothyroid or we don't have a thyroid gland, the assumption has been that we're going to convert the T4 in this Synthroid, levothyroxine, Levoxyl drug into the T3 that our body needs. But for some of us, as we're finding out from this research and also from patient experience, some of us simply don't convert that well or enough, and we end up deficient in that powerhouse hormone, the T3 that our body needs coming from the thyroid. So when we're deficient, we are still going to be hypothyroid in a number of different ways functionally. So this is really the crux of the issue, is resolving the symptoms and getting back to a place where we have enough of the actual thyroid hormone, not necessarily just a TSH level that falls within the reference range.
Right. It's important to get to the point where you feel good. I'm wondering, Mary, you are a patient advocate. You got started with your own diagnosis of thyroid disease. Would you share that with us, please?
Absolutely. I was back in 1995. I was engaged to get married. I was starting to feel very tired and draggy and a little bit blue, and it didn't make sense given everything else that was going on. I'd also never had a problem with my weight, and I was trying on wedding dresses, and every time I went to get a fitting for my dress, I had gained a size. And this was kind of horrifying over the course of a couple months, and I went to the doctor 2 or 3 different times to complain about what was going on. And after the third visit, over the course of maybe 3 or 4 months, my doctor said, I'm going to check your thyroid. And I really didn't even know what a thyroid was, what it did. I kind of knew a little bit about maybe it had something to do with people gaining some weight, but that was the extent of it. And it turned out I was hypothyroid. I had Hashimoto's disease. And I started to research, and there simply wasn't that much out there. And this was the early days of the internet. So I started to connect with a lot of other patients and also practitioners and advocates, and discovered that there was an entire world of patients out there who were struggling, who were not getting resolution of their symptoms, and also an entire world of people who were not diagnosed yet but didn't know what was going on. And so it was really the start of a lot of interaction, and we see it in all the different conditions and chronic illnesses where patients are learning what they need to know to be able to advocate for themselves.
You are listening to patient advocate Mary Shomon. That's Shomon. Her website is thyroid-info.com. You'll also find her on social media, especially Facebook and Twitter, where her handle is @thyroidmary. Don't miss her books. The most recent is Your Healthy Pregnancy with Thyroid Disease. Her previous book, The Thyroid Diet Revolution, Manage Your Metabolism for Lasting Weight Loss, was a bestseller.
Terry, the idea of combination therapy, that is to say T4 plus T3, still remains quite controversial. And I was fascinated that Dr. Antonio Bianco said that as far as he knew, no pharmaceutical company was actually researching that combination, which is kind of a shame.
It is. I certainly hope that, as he does, that they will turn to that soon.
After the break, we'll find out why people can get frustrated with the TSH test.
What can patients do if they suspect that they're not efficient at converting T4 to T3?
Are there ways to get combination therapy even though there's no real combination drug available?
How can patients work with their doctors to get the best diagnosis and treatment?
We'll also find out about the effects of low thyroid on fertility and pregnancy.
You're listening to The People's Pharmacy with Joe and Terry. Thanks for listening to this podcast of The People's Pharmacy. If you like it, why not rate or review it in the iTunes store? We'd appreciate it.
Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red-X Industries, makers of Utterly Smooth Foot Cream with shea butter, helping dry, cracked feet feel utterly soft and smooth. 800-345-7339. Online at uttercream.com.
To purchase a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is 1096. That phone number again, 800-732-2334, online at peoplespharmacy.com. You can also download the free podcast from iTunes or from our web store. We invite you to consider writing a review.
Today, we're talking about thyroid problems. Earlier, you heard from a leading endocrinologist, Dr. Antonio Bianco of Rush University. Now, we're also speaking with a patient advocate, Mary Shomon. Her website is thyroid-info.com, and you'll also find her on social media, especially Facebook and Twitter. She's @thyroidmary. Her books include Your Healthy Pregnancy with Thyroid Disease. Her previous book, The Thyroid Diet Revolution, Manage Your Metabolism for Lasting Weight Loss, was a bestseller. Mary spoke with us via Skype.
Mary, one of the frustrations, I think, for both physicians as well as patients is that for decades, people were told, just get your TSH level measured, and if it's, really high, we'll give you T4, levothyroxine. In those days, it was just Synthroid, and then you're going to be fine. And a lot of people, as we've already mentioned, didn't feel fine. And now we have a sense that some proportion, whether it's 5 or 10 or 15% or higher, don't convert the so-called inactive, or as you described it, the storage hormone T4 into the active form, which is T3, and they actually need supplementation. So how would they go about getting that? One of the things that Dr. Bianco said was, well, no drug company has come up with a combination product, that is to say a T4 and long-acting T3, that will provide, the levels that people need to feel good. So what are patients to do to solve this problem?
Well, patients are doing a number of different things in terms of working with their doctors. In some cases, they are on a levothyroxine drug like a Synthroid, and in order to supplement the missing T3, their doctor may prescribe one of the prescription manufactured brands of T3. There's Cytomel, which is the brand name, and then there's the generic T3 tablets that are available as well. And so in some cases, people will take those to supplement that missing T3. Or if you're working with a more holistic or naturopathic or integrative type of doctor, some of those doctors tend to gravitate towards compounded sustained release T3, which has to be ordered again by prescription, but from a compounding pharmacy. None of these are perfect solutions because at this point, T3 is very fast acting in its tablet form. And so people find they may need to dose several times a day to avoid a lot of up and down spikes. And the compounded T3 is not something that a lot of doctors are as familiar with or comfortable prescribing. Plus, it can be a bit more costly. So I know that there is a drug in development, but it has not been produced or gone through any approvals that would combine T4 levothyroxine with a sustained release or longer acting T3, but we're probably a couple of years still away from that hitting the market. So in the meantime, we have to make do with what's available. And the challenge really, though, is that a lot of doctors don't really know about the time release T3 or compounding T3, and even the prescription versions, the Cytomel, a lot of doctors are still not comfortable prescribing it. So it can be a bit of a challenge, even if you are one of that subset of people that don't feel well on a T4 only treatment. You're going to face a bit of an uphill battle with some practitioners trying to get evaluated and treated for that missing T3.
Now, some patients say that they feel better when they take a desiccated thyroid gland product, such as Armor, but a lot of doctors are a bit reluctant about this. Can you tell us a bit more about that?
Yes, that's an option too. Natural desiccated thyroid drugs like Armor Thyroid or Nature Thyroid have been on the market for more than 100 years, and they are an alternative to the synthetic T4 or synthetic T4 and T3 combination therapy. They are derived from the desiccated or dried thyroid gland of pigs, and they provide both the T4 and the T3 hormone in a fairly stable ratio created from these dried thyroid glands. Some patients prefer this medication. They seem to feel better and have better resolution of their symptoms on it. In some cases, that may be because it's containing the T3 as well. In other cases, we've seen people go from a combination synthetic therapy to natural therapy and find that still works better for them. So it really is an issue of what is it about the animal thyroid drug that seems to be better absorbed or better working in a subset of patients that we haven't really studied yet. So we don't know if there's cofactors or nutritional elements that are part of this tablet that may be better absorbed by some people. All we know is that it's a trial and error process, and in some people it seems to work best. It's a challenge getting it diagnosed outside the integrative or holistic field. However, although there's some endocrinologists who are willing to try it with patients as long as things aren't too complicated, but you're more often likely going to have to go to a more integrative or holistic physician to get natural thyroid without a fairly strong battle.
Now, Mary, you mentioned trial and error, and that makes a lot of physicians and especially endocrinologists nervous. So how does a patient and a doctor work together to get the best diagnosis beyond perhaps TSH, thyroid stimulating hormone, and match up that diagnosis with the best dose, whether it's a single product like levothyroxine or a combination product, so that they actually feel better? How do you do that?
Well, I think that the answer is a process that a lot of doctors now refer to as optimization. Rather than simply just handing someone a prescription and rechecking at some point to determine whether their TSH test is coming back into the reference range, some of the practitioners are getting a little bit more granular about it. They're digging down and they're getting not only TSH, but the free T4 and the free T3, the actual amounts of the circulating hormone available in the bloodstream, and they are using that to guide their treatment. Certainly, if someone has a robust T3 and needs to have some thyroid hormone replacement, a T4 medication alone might work fine for them. And so this is where the trial and error comes in, because a lot of doctors would start with a levothyroxine drug and recheck maybe 8 to 10 to 12 weeks later and see, are you back down into the reference range? This is the point at which then the issue comes in. Do you feel well? If you're in the reference range, do you feel well, and are your numbers optimal? It's not enough necessarily to be at the top of the range, for example, up at 4.9 TSH or 5. That's like saying that someone with a 99.9 degree temperature isn't necessarily sick. When some people might feel terrible with that kind of a fever, other people wouldn't notice. So for each person, there's an individuality to this. But for the most part, we know the majority of people are not up at the edge of the range. So we want to know where they are going to feel optimal, which for most people is going to be less than a 2.5. So the doctor needs to work with the patient to figure out, is the medication getting them in the range? And then once they're in the range, are they feeling well? What does that free T4 and free T3 look like? Is it in the optimal range, which would be solidly in the middle or a little bit higher, not at the bottoms of the range or at the absolute tops? So it's a balancing act. And frankly, like you said, it's a bit daunting for patients and doctors because it does require some rechecking, periodic visits, coming back after a certain amount of time on the medication to recheck the levels and tweaking of dosages. And then, of course, if the T3 is consistently low over time, that's oftentimes when doctors move in with the possibility of adding a T3 to the T4 only therapy, or even in some cases switching to a natural thyroid. So it takes time because it's, try something, see where it goes, test it, evaluate, and then go in to make any modifications. So it can take sometimes 6 months for some patients to find an optimal dose of an optimal combination of medications and settle in on it and realize, I'm really doing well with this particular dose and this particular medication.
Mary, we know that thyroid disease can interfere with fertility, can make it more difficult to become pregnant or maintain a pregnancy. Are doctors testing all women who are trying to start a family?
No, and this is actually one of the issues that I think is truly a travesty in the medical world today. We have women that are dealing with infertility, And in many cases, doctors never test their thyroid, despite the fact that we know that the thyroid has a very obvious and important impact on fertility. And if you are hypothyroid and not being treated, it can prevent pregnancy. There is actually no call for universal screening of women with infertility or for women who are planning to become pregnant or women who are pregnant. Doctors basically say, well, we use a case finding approach, which means if we think there's a reason or symptoms or enough rationale, we'll test for it either before or during the pregnancy. Meanwhile, you have women getting $10,000 a month assisted reproduction, in vitro cycles, egg harvesting, who are profoundly hypothyroid and no one has ever checked their thyroid. And of course, these processes don't work well or they fail until these women are getting properly diagnosed and properly treated. And in some cases, they need no assisted reproduction in order to become pregnant and have a healthy baby. Then we have women that are in their early pregnancy who are not getting evaluated or checked. And when we are in that first trimester of pregnancy, the baby has no functional thyroid. The baby is developing a thyroid, but it is not online yet producing thyroid hormone. So the baby relies on the mother for all of its thyroid hormone. So when we don't have enough thyroid hormone as a mother, the baby gets shortchanged, which can lead to cognitive and IQ deficits and a variety of other issues when it's on the milder level. When it's profound, when a mother is profoundly hypothyroid and not treated, then we often end up with a situation which is seen more often in developing countries, which is called cretinism, where there's permanent disability and mental retardation in children born to mothers who are profoundly hypothyroid and iodine deficient. So to me, it's such a basic issue that I think any woman planning to get pregnant should have her thyroid evaluated. And any woman who is pregnant, I think it should be part of the normal initial workup that the thyroid is evaluated and to make sure that the woman is getting enough thyroid hormone because she's producing thyroid hormone for two. And a lot of doctors are not paying attention to this. Women are having first trimester miscarriages, or if they continue the pregnancy, these babies are having some issues. There's a higher risk of ADHD and autism spectrum disorders in babies born to mothers who were hypothyroid during the first trimester of pregnancy. So there's a whole realm of issues surrounding all of this that could be resolved with universal call for prenatal testing of the thyroid and post-pregnancy confirmation testing of your thyroid. That inexplicably to me is not something that's being done, but I think it should be to protect moms and babies.
Mary, some of what you've just described is pretty scary. And I want to just go back and ask you, as long as the woman knows that she has a thyroid condition, as long as it's being treated appropriately, the baby should not suffer from these problems, correct?
Absolutely. That's the goal, because if we are supporting the mom's thyroid sufficiently and treating any hypothyroidism or deficiency in thyroid hormone, then the system works properly. The baby is getting enough thyroid hormone, and things from a thyroid standpoint and from the cognitive and developmental standpoint should be working beautifully.
Mary Showman, thank you so much for talking with us on the People's Pharmacy today.
You're very welcome.
You've been listening to Mary Showman. That's SHOMON. She's a nationally recognized thyroid patient advocate and activist. Her website is thyroid-info.com. You'll also find her on social media, especially Facebook and Twitter. She's at Thyroid Mary. She's also an author, and her most recent book is Your Healthy Pregnancy with Thyroid Disease. A previous book, The Thyroid Diet Revolution, Manage Your Metabolism for Lasting Weight Loss, was a New York Times bestseller.
And she joined us via Skype. Earlier, you heard from endocrinologist Dr. Antonio Bianco. He's the Charles Arthur Weaver Professor of Cancer Research in the Department of Internal Medicine at Rush University. He's president of Rush University Medical Group and vice dean for clinical affairs in Rush Medical College.
Joe, we spoke a lot with Mary in particular about the importance of thyroid conditions for fertility and pregnancy. I do want to point out that in addition to women suffering from thyroid problems, men can also have hypothyroidism, sometimes hyperthyroidism, and so they too should be aware of the potential for thyroid problems.
And what are some of the most common symptoms associated with hypothyroidism?
The most common symptoms would be especially fatigue, getting tired easily when you exercise. Dr. Bianco mentioned cognitive problems like difficulty concentrating, fogginess, constipation, dry skin, hair loss. All of those things are quite common.
And one that I've always found particularly fascinating, when people lose the outer third of their eyebrow, that sometimes is an indication of hypothyroidism. And clearly, in order to diagnose and treat this condition effectively, it requires really good communication with your health professional.
That is absolutely true. And that is all the time we have today. Lynn Siegel produced today's show. Al Wadarski is the engineer. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible by Red X Industries, makers of Utterly Smooth Extra Care 20 Cream with 20% urea for extra skin protection. The number is 800-345-7339. The website is uttercream.com.
And if you would like to purchase a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1096. That number again, 800-732-2334. You can also make that purchase on our website. It's peoplespharmacy.com.
When you visit our site, you can share your thoughts on today's show. You'll also find extended interviews with both Mary Showman and Dr. Bianco. You'll learn the latest details on both diagnosis and treatment that we could not cover in our limited time. If you like, you can also share your own story about your thyroid problem in the comment section of today's show. You'll also find a guide to thyroid hormone on our website.
At the website, you could sign up for our free online newsletter. It comes every day in your email, or the free podcast of the show. That's once a week. You can listen at your own convenience or share it with a friend. And we'd appreciate you rating our podcast at iTunes or wherever you subscribe.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.
Hi, I'm Chris Gethard, and I'm very excited to tell you about Beautiful Anonymous, a podcast where I talk to random people on the phone. I tweet out a phone number, thousands of people try to call. You talk to one of them, they stay anonymous. I can't hang up. That's all the rules. I never know what's going to happen. We get serious ones. I've talked with meth dealers on their way to prison. I've talked to people who survived mass shootings. Crazy funny ones. I talked to a guy with a goose laugh, somebody who dresses up as a pirate on the weekends. I never know what's going to happen. It's a great show. Subscribe today, Beautiful Anonymous.